Good morning, everyone. Um, so this talk is being, I'm doing this talk primarily from the perspective of Escape Next. And presumably, if you're seeing this talk, you're probably seriously thinking about participating in Escape Next. And the aim of this talk is to give an overall big picture view of multi-phase CTA, some of the publications around it, some of the evidence around it, why we think it's a good technique, why we think it has advantages over other techniques, where the future is going, and also in terms of why we are using it in Escape Next. These are my disclosures. I do work with a bunch of device companies. As we know, of course, endovascular treatment is the standard of care, and I don't think there's been that powerful an evidence in the recent future related to any medical condition. The treatment effect is massive with an NNT of 2.5 in the Lancet paper that we wrote through the Hermes collaboration. And as of right now, as of today, the only thing that works for acute ischemic stroke is opening the blood vessel. And we're hoping through Escape Next to show that there'll be something more. And this is a slide that I made probably 10 years ago, and hoping with your help, we'll be able to change this slide and show something else. But at the end of the day, every step along the way, for example, measuring NIH, just looking at these maps and stuff like that, are just stuff along the way that one has to do. And there, some of them are necessary steps, some of them are not necessary. But irrespective, they're just steps along the way. They don't really sort of help the patient. And given that we know time is brain, we should minimize those steps to the maximum possible. We know that the brain is not the heart, and as I like to say, never have respect for an organ that can be transplanted. As you know, this is Dr. Christian Bernard, South African doctor who did the first heart transplant and, so to speak, made the heart a disposable organ. We don't really understand brain eloquence. So just to give an example, this is a youngish person, 60-year-old, right hemisphere syndrome, NIH 18-ish, 50 minutes from onset. And this is the kind of situation where I don't really care what the imaging shows. I'm going to go open the vessel. Now, this person had some changes here related to aspects, had not so good collaterals on the multi-phase CTA, and I'll tell you more about it, and has a carotid occlusion. But anyway, we went ahead, went in, got in pretty quickly, opened the vessel, standard kind of technique. The vessel is open, TK3, 95 minutes from onset. But here's the thing about it. This is the 24-hour MR showing all those diffusion changes, except the patient is nearly back to normal, NIH of 3. And this is an interesting idea of the disconnect between imaging and the patient outcome, and which we were seeing more and more as we got better and better at opening the vessels. And I've been thinking about this a long time. So I put together a worldwide group, and we recently wrote this thing in terms of challenging the idea of ischemic core. And one of the things we wanted to get across in this paper was that we should stop using the word core because it has a sense of depressing around it and feeling like that it's inevitable now. And we sort of came up with an interim term, SIT-UV, severely ischemic tissue of unknown viability, which recognizes our limitations. And this is a picture from that paper, that there's some changes going on here. This is the red and green map showing this red is dead. We opened the vessel pretty quickly. Firstly, that red area tissue did not die. Secondly, the patient had a great outcome. The patient's NIH dropped to 5 from 18 and overall went to an MRS of 1, which is not what one would have thought with that kind of an M1 occlusion and those kind of changes. And we've been thinking about this a long time. So Meryl Boers, who was in Amsterdam and did a PhD related to this, she wrote this paper in two papers, one in JNIS, one in JAMA Neurology, through the Hermes collaboration. And this is one which shows that all these patients with large infarcts had good outcome and all these patients with small infarcts had bad outcome, showing the lack of correlation between infarct size and outcome. But the more interesting part was, and this is a paper in JAMA Neurology, and somehow it got missed and it wasn't sort of as well publicized kind of thing. So this paper, here's an example. So these were infarct volumes that she painfully sat and measured at 24 hours. So these are not baseline infarct volumes, and the level of precision around the measurement is going to be much higher. So imagine a person has a 50 cc infarct and they're in the control arm versus the endovascular arm. And with the same infarct volume, the endovascular arm patient did much better. And when the first time I saw this result, I was sort of completely shocked by it. What can be a possible explanation? And I do think the likely explanation is selective tissue loss, that in endovascular patients, there is selective tissue loss, and what we are perceiving to be infarct still has enough tissue alive within it, which forms the substrate for brain plasticity and for recovery. In the late time window, obviously, we know about the DAWN and Diffuse 3 trials. When I saw the results of these trials, the most interesting part for me was how badly the control arm did, 13% versus 16% in the other one. So it doesn't take much to beat it. And assuming that you have a desirable NNT of something like 10 or 12, which is probably still better than most of medicine, You just need to have a good outcome rate of 20%, which means the bottom line is these trials were highly, highly selective in the way that they chose their patients. And obviously, we are leaving a lot of patients behind who could have benefited from treatment who did not by choosing it that way. We in the ESCAPE trial, we had enrolled patients up to 12 hours, and even though we had only 53 patients who were beyond 6 hours, we had very similar results. This is published in AJNR. Obviously, it did not reach statistical significance. A bunch of people, Tudor Joven leading the way, put together the Aurora group, which was all the late time window patients. And this was presented in ESOC. So these were the breakup. Obviously, it was led by Dawn in Diffuse 3, and then ESCAPE had 49 patients, positive revascat, etc. They put all the patients together. They were reasonably well matched in terms of their treatment arm control arm. The other interesting part was the complication rate, whether in EVT or in control, was very well matched to Hermes. It was no higher just because they were late time window patients. But here's the interesting part. Whether we look at aspects in a dichotomous way, just by aspects 0 to 7 versus 8 to 10, they were all centrally read aspects. There was sort of benefit of treatment. And even if you did it in a trichotomous way, 0 to 5, 6 to 7, 8 to 10, in 6 to 7 and 8 to 10, there was clear sort of benefit of treatment just by simple reading of aspects without doing any complicated imaging. Now, just to remind you though, most of these patients were for Dawn and Diffuse 3, chosen using complicated criteria in which most of the patients did have good aspects as expected. Now, what about ESCAPE NA1? So in ESCAPE NA1, we again enrolled patients up to 12 hours. And what we did was we had 110 patients who were beyond 6 hours from last seen normal. Selection was based on multi-phase CTA, and they were in the control arm. So, and we compared it to Dawn and Diffuse 3. So as firstly, we were much faster. Flow to groin was much faster, imaging to groin was faster, our TICI 2B3 was the same. Well, there are multiple reasons for being faster. One is society as a whole has evolved and we are faster. But another possible reason is we didn't have any complicated perfusion imaging. We chose patients just based on multi-phase CTA. And the interesting part was the final infarct volume at 24 hours. That was higher for ESCAPE NA1, and that could be, we don't have a standardized technique of measuring infarct volume, so it's possible. It's possible that this was just a way of differences of technique and so on and so forth kind of thing. But here's the interesting part. The outcomes were essentially identical between ESCAPE NA1, Diffuse 3, and Dawn in terms of MRS02, etc. But this is super interesting in terms of we had a much more easy criteria of selection. We were faster, and we still achieved the same kind of outcomes. We had the same TICI 2B3 rate. So which is sort of providing further evidence to the fact that you don't need complicated imaging. Speed is important. So essentially, now coming to EVT decision making, you have three choices. Go for endovascular treatment, don't go for endovascular treatment, or wait for more information. As you're waiting for more information, neurons are dying. And at the highest level, what is the information we need? Is there intracranial hemorrhage? You get that on non-contrast CT. Is there a target occlusion? You get that on CT angiogram. And then there is this idea of, is there a wipeout? Is there complete death of tissue, which is sort of a poorly understood phenomenon. Like we said in an article, that is what is defining core is about. And then the other part we have to think about it is, let us say we call a certain amount of tissue as dead. How sure are we? How precise are we? And is that precision even possible? And then the last part of it is we talk about this mismatch volume. And is that mismatch volume sort of a myth? Can we even define penumbra? We can't even reach to a consensus of defining penumbra, let alone sort of measuring it. The other part that is there is, if a person has significant clinical deficit and does have a small core, obviously they have penumbra. So that's the other part which is relevant. And then I like to talk about this denominator fallacy, which you probably heard me talk about before. We've written this twice now from different perspectives, but just to sort of remind you, imagine there are two cities, Gotham City and Metropolis. Imagine they have 200 people with M1 occlusion greater than 6 hours. Remember, I'm talking about greater than 6 hours. This less than 6 hours situation is actually clearer. And imagine Batman is sort of a simple kind of guy. The CT angiogram takes 120 out of them to endovascular, 60 have a good outcome. So Batman writes a paper in stroke saying I have a 50% good outcome. As to Superman is very particular about Dawn Diffuse 3 criteria, MR, CT, perfusion, etc., measuring volumes. Takes 20 patients to endovascular, 90% of them have good outcomes. So, Superman tells Batman, my outcomes are better than yours. But is that the real truth? The real truth is that in Gotham City, 30% had good outcomes, 60 out of 200, as opposed to only 9% in Metropolis. And that is something to be cognizant of. We have a super, super powerful treatment that is safe. And we have to be careful about not leaving patients behind who could benefit from treatment just because a certain green and red map shows you A and B number, which are probably not that precise and accurate anyway. So here's the trade-off between information availability, robustness, so on and so forth, your comfort level, your quality of interpretation, you've been sitting in bed and looking at green and red maps. You can only do a non-contrast CT, go straight to angio, non-contrast CT, single-phase CTA, multi-phase CTA, CT perfusion, MRI. And in theory, you get more information. I'm not sure you add on to your improvement of decision-making, and I'm going to show you some data on that. Now, obviously, we have chosen a middle of the pathway kind of thing, non-contrast CT plus multi-phase CTA for the purposes of trial, but my multi-phase CTA. Well, the pros are you have no compromise on speed if you're doing a CTA anyway, just 15 seconds of more imaging time. It is available anywhere. You can do a CTA, you can do a multi-phase CTA. It's not vulnerable to motion the same way a CT perfusion is. It does provide some degree of functional information about the collaterals. The radiation dose is much, much lower than CT perfusion. There's lower cost. You don't need any complicated post-processing software. In terms of cons, there is a con. If you're used to the idea of green and red maps and taking decision, yes, currently you won't have those available. And you currently won't have infarct volume quantification. Although I would say that does add to confusion because those infarct volume quantifications are generally speaking incorrect for the data that I already showed you. We have written papers on this and so have others, and I'm going to show you some data on it. So overall, collateral grading allows for outcome prediction compared to single-phase CT and multi-phase CT and LVO strokes. In fact, Esme Venema, she did her PhD in Netherlands. She did build that Mr. Predicts model, and in the process of building the Mr. Predicts model, when she was looking at factors that are relevant, in fact, collaterals was such an important factor that even aspects got thrown out of her model when she was building it. There's excellent inter-rater agreement, and obviously we talked about less radiation dose. In fact, this was the first paper we wrote on it describing the technique, and this was in 2014, 2015 kind of time frame. And recently we analyzed the data in greater degree of detail, and this is under review right now. It's already got accepted, so should be out soon. So these are the total data set, 464 patients. And what is interesting is that if we looked at mCTA-based decision making, 202 would have gone to endovascular treatment. However, if we did it solely based on CT perfusion and eligibility as was defined in fifth prime, etc., 61 would have gone to CT perfusion. But the interesting part is that the probability of good outcome was very high for those patients who were mCTA eligible but CTP ineligible, showing that we are not making bad decisions. Yes, this is not a randomized data set. Yes, this is from a registry kind of situation. But at the same time, by having a greater degree of inclusivity of decision-making towards endovascular treatment, we did not compromise the degree of good outcome level. Other people have written about it in terms of higher detection of LVOs compared to single-phase CTA. This is from we work very closely with the guys from Ireland. This is another paper on delayed PL vessels. This is from the guys in Czech Republic. Petra is doing a fellowship with us right now. They've written about it. And then this was when Amy was a fellow with us. In terms of detection of not only big occlusions, but small occlusions as well becomes much easier. Just to give you examples of small occlusions, this is how it plays out. So if you have an M3 occlusion, what our fellows and residents do is they often go to the second or the third phase, and if they see this asymmetry, they know that there has to be something going on to more proximally, so they start searching for it and they find it. So this is an M3 occlusion, and this was where it was and matched up with what we were expecting to find on the perfusion imaging. Same way, this is an asymmetry at the ACA level that you find over here. There's this vessel that is hanging around, and this person on perfusion imaging has this ACA deficit, and on follow-up has this ACA infarct. And similarly for PCA, there is a PCA occlusion. There are these vessels hanging around. So the second and third phase, very often our residents and fellows look at the second and third phase first, and that way they know that something is going on, and then they go back and find the occlusion. So it actually increases the efficiency of interpretation of a CT angiogram. So this was the follow infarct in this patient. This recently came out. This is from showing that it can identify pseudo occlusion as well, in addition to identification of the true occlusion. And obviously, in terms of data, this technique was used in ESCAPE and ESCAPE NA1. So it's not like something which is in some ways inferior to other techniques. This has been used in two of the big randomized trials, one for EVT versus no EVT, one for NA1 versus no NA1, and has been used worldwide kind of thing. So at the end of the day, it's been used in two big publications. Now, Mr. Clean Late is going on, which is looking at selection of late patients outside of the Dawn and diffuse 3 criteria. And excuse me, and they're doing it based on single phase CTA. We'll see how the results play out in terms of they're more than halfway done right now. Now, what about cost effectiveness? So there's two ways to look at cost effectiveness. One is to look at it from a time perspective. The other is to look at it from a true perspective, true money spent perspective. So bottom line is, from a time perspective, we wrote this paper. Wolfgang, who was with me at that time, was the first author on this. This has got published in Stroke. $1,000 per 1 minute delay based on American data. So the faster we can do it and save time, and we have enough data. We wrote a paper from Swift Prime showing that the patients who did not have CT perfusion were on average 14 minutes faster. So that's one very simple way to look at it. The other way to look at it is just the cost of doing CT perfusion, whether it is the tech time, the machine time, the radiation, the contrast, the post-processing software, whether you have rapid, whether you have brainomics, so on and so forth, the cost of doing that. So all that adds up as well. So in terms of sort of cost effectiveness, what has been shown is CT angiography is cost effective. This has been done across multiple different studies. And MR is generally less cost effective because it takes more time. CTB could potentially be cost effective, but it's the under treatment bias. And that is very, very difficult to calculate when you do these cost effectiveness studies. I've written many papers on this now. That one of the things when you write from Hermes, when you do cost effectiveness, is you are only limited to that what was part of Hermes. You don't know all the patients that missed out getting treatment and how it was affecting sort of the cost effectiveness part of it. So basically, we are thinking of going in the middle. What about the practical aspects of doing it? So it can be done, as I said, on any machine that a CT angiogram can be done on. So your first phase of CT angio is standard. Then you come back to the base of skull, go wait for a little bit, go up a second time, come back to the base of skull, wait for a little bit, go up a third time. Now remember, in the second and third phase, you are doing only the brain. So the first phase is your standard head and neck. The second and third phase are only the brain. And firstly, there's multiple reasons for it. Firstly, why bother looking at the head and neck again? But here's a general rule about radiation. So if you had a chest, neck, head CT angiogram, majority of the radiation dose comes from here, some bit comes from here, very little comes from here. And since your second and third phase is only over here, you're hardly adding any radiation dose. And when we calculated at our sites, the second and third phase of the multi-phase CTA had radiation dose that was equivalent to half a head CT scan. So practically sort of close to zero radiation if you think of it from the perspective of an old person having a stroke, as opposed to the radiation dose in our CT perfusion, not to mention the fact you need additional contrast as well, which produces, and the additional delay as well. So this is the final result as it comes out. This is the non-contrast CT. Then you get phase 1, phase 2, phase 3. And you can set it up in such a way on any scanner, whether it's GE or Siemens or Canon, that these phases come out sort of automatically built up. We will tell you the protocol around it. Usually what we do is we make them 25 millimeter thick, 3 millimeter apart, and you set them in such a way that as you're scrolling up and down, you sort of see the three phases simultaneously. But one thing that it tells you is you look at this and you know there's approximate visual occlusion. Second thing is you look at this, you know there's good collaterals. Third thing is you get a flavor for how quickly collaterals are coming in and washing out. So all the information that you need. During the days of Escape in 2013, we had one site that had an 8-slide scanner, which was super slow. Even in that site, we could do a multi-phase CTA. The only difference that we did at that time was that effectively it was a first phase and a third phase because the time gap was such that it took that long. In any 64-slide scanner and higher, you can easily do it. If you happen to have a GE scanner, there's a software called Fast Stroke that does everything automatically, separates out the images, reconstructs them, shows you as you want it, as you would plan the procedure itself. And then they have this add-on software called ColorViz, which does color coding of collaterals. We'll provide you detailed setting up this thing, where you should start, where you should end, what should be the gap, what should be the auto trigger be. For example, this is built for Siemens Somatome, and we can provide you all this information as you need it and help you sort of set it up so that you minimize the tech setup time. You set it up consistently each and every time. How much contrast do you inject? What kind of contrast strength should there be? And in addition, how do you set it up so that it comes over to your packs instantaneously? For example, this was a video I made for setting it up on a Siemens Somatome 64. It's available on YouTube. This is one I made for setting up a GE scanner, which is available through this Vimeo password. We don't have video set up for Philips and for Canon, but we are happy to sort of work with you and set it up. So there are three phases. The first one is a standard head and neck. Like I told you, most of the radiation comes from the neck and the chest. The second and third phase is only for the head. By a process of trial and error, we decided that the gap between phases should be 8.5 seconds. So this is a way to think about it. If you think about one particular voxel, so let's say at the point of right ICA bifurcation, you're seeing 3 points, 3 time points, 8.5 seconds, 8.5 seconds, total of 3 time points. So a total gap of 17 seconds. Now, why 8.5? Why not 8? Yes, it doesn't really matter. You can do 8. Why not 4 phases? Why 3 phases? Yes, it doesn't really matter. We found a process of sort of optimization by trial and error. And overall, big picture, we know from CT perfusion studies, from MR perfusion studies, what the general mean transit time, etc., is in a setting of M1 occlusion. So we thought 17 seconds was long enough to give you a general feel for what the mean transit time or Tmax through the tissue is. So overall, it's worked well. We've been doing it now for 6-7 years, and we have never needed to change it. It sort of works overall very well, and now we have data from multiple different setups. So in terms of setup, we have a lot of experience. We found that any experienced technologist can set it up in 10 minutes. As an example, I was in Copenhagen during the days of Escape. We just went over to the scanner, worked with a technologist. 10 minutes later, we were able to set it up on that scanner. We like to have the presentation of data so that the 3 intracranial phases are next to each other, so that as you scroll up and down, all 3 of them move together, and that makes it super easy to determine site of occlusion, collaterals, etc. So, obviously you want peer collateral backfilling and the site of occlusion. And then essentially, in addition to that, in your mind, you can get a temporal assessment of sort of how the collaterals are going in and coming out. And obviously, as we go towards the idea of MEVOs, medium vessel occlusions, you may have seen papers written by us on this topic. So it's becoming very easy to determine MEVOs as well on this, as I showed you in some examples. So in terms of Escape Next, what are the kind of patients that will qualify? Basically, it has to be proximal vessel occlusions. So this would be an ICA TNL occlusion. That would be a person suitable based on site of occlusion. This would be a ICA terminus M1 occlusion. This would be a proximal M1 occlusion. This would be a mid M1 occlusion. This would be a distal M1 occlusion. And these are the kind of patients who would be suitable for inclusion in Escape Next. In terms of collateral assessment, the big picture is that we want to exclude patients with no collaterals or poor collaterals. And there's multiple different reasons for it. One simple reason is if there's no collaterals, the study drug, which is a neuroprotectant, will not get there. That's one simple reason. The second reason is we want patients to have a reasonable chance of having a good outcome, to be able to discriminate between what the control arm and treatment arm is. The third reason is that our primary outcome is dichotomous MRS02 versus 3.6. It is not a shift analysis. So let us say if you take a person with poor collateral and through the process of NA1, hypothetically, let's say the person shifts from MRS5 to an MRS4, that is not useful for the success of the trial. So all these factors put together, what makes sense is to exclude these patients. In addition, we also have data from Escape NA1, the subgroup that did not receive TPA, that in those patients who did not have good collaterals, there was absolutely no signal. Now, mind you, though, that's a subgroup of a subgroup, so it is of limited validity, but at least it makes sense in terms of sort of what we think about it from a pathophysiology standpoint. So who qualifies for Escape Next? This would be like a perfect candidate, M1 occlusion. Even in the first phase, you can see collaterals. The third phase, the collaterals are hanging around, so there's a slight increase in mean transit time, but this would be obviously suitable and would qualify for the trial. This is the kind of person who has pretty poor filling of the collaterals here. So this would be the kind of person where you would think that maybe this is not suitable, not to mention that this person has also got asymmetry of the ACA, which is probably the reason why they have asymmetry of collaterals as well, sort of thing, would not qualify for the trial. This is the kind of patient where we think this is what we call a black hole. So instead of, so to speak, 2 million neurons a minute, maybe there are 2 billion neurons a minute that are dying. So this is the kind of situation where there is no hope of getting any drug into the tissue that needs it. So this would be a person which would be clearly a no, they have just bad collaterals, and this would not be suitable. In terms of multiphase CTA, what is coming up next? So this is multiphase CTA derived Tmax map. This is the Tmax map from the CTP. So as you can see, just with 3 phases and using the base phase of the non-contrast CT, technologically we are able to build it. Is it available as a product right now? We are hoping that one of the companies will have it as a product within the next 1 year or so. So that is yet to come in, kind of thing. But at the same time, it sort of is pointing into the direction of that at the end of the day, if we acknowledge the fact that we can't recognize the core, then at least what this does is it tells you instantaneously, yes, there has to be a sizable occlusion to create this kind of a map. So then you can go find the occlusion. And yes, there has to be some contrast coming in through there, which is practically sort of the information that you get out of CT perfusion. What is currently available, and we've written extensively on this, is this idea of collateral color map. So here, as you can see, that there is a difference in the color of this thing as it's coming in through collateral. So all this green is sort of retrospectively filling. And again, it makes identification of the occlusion easier. It helps you get a mental picture of what the collaterals are like. So basically, it makes it into a color map where red is the first arterial phase, green is the second peak venous phase, and blue is the third late venous phase. And in the previous example, since it's green color, it's middle of the range, they're decent collaterals kind of thing. So you can show this even at the level of an M2 occlusion. For example, this vessel is green. That means it's filling in through collateral, so it makes it much easier to detect what's going on in terms of the summation of it. So essentially, once again, this is sort of green, few areas are blue, which are some of them are true veins, but essentially because all these vessels are green, you know that there's a one phase delay in the filling of the vessels. And this was what it was on follow-up, so sort of overall makes sense with what we were seeing. So again, in terms of this thing, there's a lot of hardly any color here. There's a little bit of blue. So this is like super slow filling. There's no green color either. So this was this was mainly blue versus no color kind of thing. So this is a situation of bad collaterals, and this person on follow-up has a massive infarct. So once again, makes the whole decision making easier. Even though this person on proximal vessel occlusion, if you don't see green and red in the collaterals, then chances are they're super flow, soft flow collaterals. And in this case, there was hardly any blue either. This is great for detection of distal occlusion. So this tiny vessel over here has a different color compared to red. So first thing you need to determine is, are you seeing an artery or a vein? This one, based on your knowledge of anatomy, you know it's an artery. And there you can see that clearly there is a tiny occlusion over there, which leads to a small little infarct. So basically adding the color adds on to the speed of interpretation of information, especially if you're in the middle of the night, you're a tired resident working through the night kind of thing, makes it easier. What about radiation dose? We formally with the phantom measured it at our place when we started doing it. So just as an example, the 2 additional phases of the multi-phase CTA is half a head CT and is 20% of the dose, sorry, 1/3 the dose, or less than 1/3 the dose of a CT perfusion. So this is in millisieverts. So this just gives you a flavor for, you don't have to worry about the radiation dose. And this was another randomly, we just picked it up relatively recently. So the perfusion CT was the same as a CTA head and neck with multi-phase CTA put together. And out of this, a very tiny proportion was related to the additional 2 phases. So really speaking, there is no downside to it. Practical decision making, if you're outside of the trial, how do you think about it? The way I think about it is, if the patient has substantial deficit and you're struggling to read the aspects, the changes are not clear, or go open the vessel. If the collaterals are good, go open the vessel. In fact, at our place, what is increasingly happening is that you get a call from the fellow at 2 a.m. says basically NIH 18, M1 occlusion, good collaterals. We've stopped talking about aspects because we find it doesn't matter. And in fact, let us say hypothetically, the person had a stroke, fell down, banged their head, have subarachnoid hemorrhage. I don't even care about that. That influences the TPA decision, but does not influence my decision in a person who has an NIH of 18 in terms of sort of going and opening the vessel. So is single phase good enough? In most situations, probably yes. However, we find multi-phase CTA makes LVO detection easier, collateral evaluation more possible, ability to detect medium vessel occlusions, interesting technology, CDP lookalike maps are around the corner. There's really no downside, no additional contrast, 17 seconds of additional imaging obviates the need for CT perfusion. And the other part is, one of the things that is important for us is not including those patients who would potentially be noise for the trial, who have no possibility of having a good outcome, which is the patients with bad aspects and stuff. So given that aspects could be tough to read, especially when you're trying to do too many things, think about consent, randomization, giving the drug, it just makes it easier to sort of prevent that from happening. Now, there's another aspect of it. Why are we using multi-phase CT and escape next? Firstly, at the end of the day, the reason for doing the trial is to take the drug to the finish line so that neuroprotection doors open up and it becomes available to human beings and improves further outcomes. From that perspective, generally speaking, for all drugs, you need 2 trials. And those 2 trials have to be asking the same question and forming the same methodology. So at the current moment, we want to be totally consistent with what we did in Escape NA1 and basically repeat the experiment, so to speak, in the no TPA arm of Escape NA1. So our idea is to keep everything the same across the trial and make it such that, you know, we submit trial 1, which is Escape NA1 no TPA arm, trial 2, which is Escape Next. If it's successful, has similar results to sort of FDA, EMEA, et cetera, all over the world. The other part that is there is we do find it's an appropriate balance between time spent and information. And in fact, we generally find that because of the reasons I described to you, what is defined as core and CT perfusion is incorrect. And obviously penumbra is incorrect. We can't even correctly define penumbra. There's no complicated or expensive post-processing. And then hopefully we have sufficient data at the end of it all that we can help other people realize that even beyond 6 hours, you don't need to follow the complicated dawn and diffuse three criteria. But in the overall big picture, we look forward to working with you in Escape Next, taking us through this journey from Mike Timiansky's point of view, which has been more than a 20-year journey, to take us to completion and hopefully continue to improve stroke outcomes. And we are willing to work with you as much as it takes to help you set it up, to get you comfortable. We've created teaching sets around it. We can work with your chief technologist to help you set it up. Obviously, we've created videos for Siemens and GE because those are the machines that are available to us. We don't have training videos for Philips and Canon, but we are totally happy to work with you. At this stage, I'm going to stop, and obviously Michael and I are available all the time to answer questions and move this process along. Thank you very much. How do you